And here at the University of Victoria, we acknowledge and respect the Lekwungen, Songhees, Kapusim peoples whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. Many of you are joining us from other locations, and I encourage you to think about the land that you are currently on and your relationship both to the land and to the peoples of that land. In particular, because we are thinking about our relationships, I also encourage you to think about the ways that health informatics can further the acts of reconciliation as we move forward. I'm really excited today to have Dr. Marcy Antonio talk to us about medication affordability and also some of the other work that she's doing within the digital health equity space. And so I'm going to go ahead and turn this over to her. She said, please feel free to ask questions throughout the presentation. For those of you who've been here before, you know the drill. For those of you who are new to this particular format in the webinar, we don't have the chat for you to enter into. You can see it, but you can't enter things in. So we encourage you to use what's called the Q&A button. And you can type your questions in at any time, and we will wait for those moments when she takes a breath. We'll ask her those questions for you. So feel free to keep typing in. You can also raise your hands as well. Okay, so without further ado, I'm going to go ahead and let Marcy take over. Thanks.
Wonderful. Thanks, everyone. And I believe you can see my screen, so I think we're all set to go.
Yep.
So yes, I just wanted to, today what I'm going to be talking about is a paper that was published in JAMIA, so the Journal of the American Medical Informatics Association. And it was recently published in June, and I'm just trying to I just realized there's one, I don't think you can see the screen of you, can you? I have something showing right on my screen.
No, we just see
No.
your slides. Now we see
Okay.
the flower.
Okay, perfect. All right. So this flower actually is a local flower. It's the tiger lily, and if you walk around the land of the Songhees and the Squamish and Saanich peoples this weekend, you might actually see this flower in bloom. It serves for me to signify the importance of the land acknowledgement. Over the weekends, I actually participate in invasive plants removals to really help with indigenous practices and decolonialist practices. Um, and so for me, it also signifies the importance of creating healthy environments so that people can thrive, or as we see here, so that the plant can thrive within the conditions that it lives. So today, what I'm going to be going through is the paper on medication affordability. And what we're going to do is assess how access to affordable medications in Canada can create inequitable health outcomes. Review results from the environmental scan of medication affordability resources for US-based cases, and then examine the administrative burden and associated costs patients may encounter when navigating medication affordability resources. And then have a discussion at the end around possible health informatics strategies. I'll go through the one that we proposed in the paper, but welcome other suggestions as well as we wrap up. So I wanted to thank the team who really was integral in this work. We have Dr. Jenny Lee Swallow and Kristen Kaisers, Divya Jaghar, Young Hee Hong, who really helped with the environmental scan, Dr. Rachel Richardson and Dr. Tiffany Vino, both who helped supervise your overall work, and then Dr. Tommy Toscos and Dr. Mindy Flanagan from Parkview Miro Health Center, who really are part of this ongoing work in looking at medication affordability. So I wanted to provide a bit of background on the medication affordability in the Canadian context, just to kind of ground ourselves and to show how this relates to the paper that was published on more the US context. So I have a couple of polls that we're going to launch. The first question I have for you is, how many private health plans are there in Canada? 500 to 1,000, 1,001 to 5,000, um, close to 5,000 to 20,000, 20,000 to 50,000, or 10,000 to 100,000. So we have answers all over the map, which is great to see. Is I actually was surprised at the number. This was from a study that was posted on the Government of Canada's website in 2019. So I wasn't able to find an up-to-date number, but I am wondering if this is actually even larger. And they found that there are 100 public prescription drug plans and over 100,000 private health care plans in Canada. So just to show how many possible resources could be out there and the range of different plans that may be available for people. The next question I have is the percentage of people in Canada reporting not taking their medications because of cost, is it 7%, 22%, 33%, or 43%? So we have 22%, 33%, or 40. Most people think 43%. The answer actually is 22%. And there's a couple of studies that speak to this, one from the Heart and Stroke Foundation and the other from Statistics Canada. This number actually is very similar to what's being reported in the United States. So I found a few studies actually both that cite 23%, both in Canada and the US. There's a recent study actually that just came out of the US. So showing that this number is now at 43% with recent policy changes. The 7% is actually a US statistic for people who have private health insurance. And they actually don't have struggle. That's the amount of people who might not take their medications because it costs. So private health insurance really helps there. The 33% reflects people in BC, older adults who don't have private healthcare insurance, which I was actually surprised to see how many older adults actually don't have private healthcare insurance. And then 40 and might not be able to cover the cost of the medications. The 43% also, a number that is similar to that I found was 44% of Canadians who don't have some type of insurance are not able to take their medications. So the importance of having resources available so that people can actually follow their medication regimen. All right, the next question I have is how many farmer care plans are offered to help British Columbians pay for their prescription medicines? So, um, so the answer actually is 13. There was a recent announcement for a federal farmer care plan, so that's within those 13. But there's also different plans based on your healthcare setting. So if you're in long-term care, for example, might be for your health condition. So there's a specific one for cystic fibrosis. There's also specific plans through the First Nation health benefits. And so there's just these numerous plans that people quite often might not know that they can actually qualify for. So what I'm starting to see in Canada is increased recognition of the medication affordability challenges. And you also see pharmaceutical organizations coming out with different programs. So what you'll see here is just six of the types of resources you can find. So there's pharmaceutical assistant programs, and these are offered by pharmaceutical manufacturers. And what's involved is patients complete an application to demonstrate their financial status. And two examples are offered through Pfizer and AstraZeneca. You then have also financial assistant benefit cards, which is a unique thing I found in Canada compared to the US. And this provides a discount card based on income. And you don't necessarily have to provide your income when you apply, but you may be audited down the road. And then there's coupons, which are offered from third-party benefit managers, and these provide discounts across the pharmacy network. And the example is from the Canada Drugs Direct site. There's also saving cards, which are where the pharmaceutical manufacturers actually provide discounts across the pharmacy network on the brand name medications. Um, there's also loyalty programs. So you have these pharmacy-based programs where if you have your medications, you can collect points. And then for those of you who are on UVic's health plan, I looked up Pacific Blue Cross. There's the private health insurance list that they have of preferred pharmacies, and so you can get different discounts based on that. Um, what I wanted to show from this slide is that there's a whole series of different organizations providing discounts. And so how do you know which one is providing the discount and how do you actually vet that? What types of processes might be involved? So do you have to complete an application or do you have to just go to your pharmacy and then you get the discount? So what we are starting to see is that the local health authorities are recognizing the resources that are being available, but yet people might not be aware that these are being offered. So for example, we have Vancouver Coastal Health Authority has this now on their website where you can find out about possible resources. Currently, the patient-facing tool is a link that provides you details on pharmacare. There's also a provider-facing tool, which I wasn't able to get access to, but I imagine that gets more into the specifics of different resources beyond pharmacare. And so what are these resources actually trying to do when we think about health equity? If we look at what we're seeing as in health inequity, it's really around the cost-related medication non-adherence. And so people aren't able to take their medications because they can't afford them. If we actually help people access medication affordability resources, they'll be able to get timely access to their medications. And then this will help with their medication adherence so they can have improved health outcomes and quality of life. This is really what the focus was for the paper that from Jamia was to understand how these resources might actually be helping with health equity or how they may actually be discouraging people from accessing the medications. So our team did an environmental scan. Um, and what we did was we searched for possible resources available in Michigan. So we wanted to narrow it down to a single area so that we could look at local resources. We looked at patients with atrial fibrillation and related comorbidities, so type 2 diabetes, heart failure, hypertension, and hyperlipidemia. We then developed a list of the common medications by consulting with pharmacists and also going to websites that had lists and also good clinical practice guidelines. And from there, we extracted information about the resources available for these medications. We then also reviewed the eligibility criteria, the timelines for how long it might take to get the medication resource, application processes. So do you need to collect signatures? And where do you actually send the application? And then the other thing that we did that I'll go through is we did an analysis based on what patients would need to do when navigating these resources. And we mapped that to administrative burden theory. So overall, we had 101 medications across those 5 conditions. And what we found was there were 66 different resources that patients would have to navigate. And they differed by the type of organization, whether they were a pharmaceutical manufacturer, a pharmacy chain, or a nonprofit organization. Down at the bottom here, you'll see there's how we also found when we categorized it, there were 12 different types of different resources available. So ones that I didn't see in Canada that haven't been able to find, but they may exist out there, are more these short-term supplies of free samples or disaster relief. We found that there were 14 patient assistant programs. So those are again where you have to complete a detailed application. And then there's also these things of copay savings cards or coupons to help reduce your medication costs. when we look at those 14 pharmaceutical assistant programs, we want to understand what do people actually have to complete on these applications and what and the range of questions that people might be asked. So what we found is that most applications have been categorized according to patient information, insurance coverage, financial information, health information, provider information, and additional signatures. So this was pretty standard. Questions up here were pretty standard around your contact information. Some asked around residency status. Some actually asked about social security numbers and to ask for your full number or for the last four digits. There's also questions around insurance coverage, and that required either proof of entering the number or having to actually send in a copy of the card for your health insurance. I'm going to look specifically at some of these categories just so you can see the range of information that was requested. So the first one is looking at income calculation. And when we look at specifically the first two categories under financial information, we find that uh, we find that we have this income calculation and the number in the household and just the range of questions. So there's a total monthly household income, but what's not clear from this one is that gross income or is that after taxes? Um, People were asked also instead of just providing their household income, it was their salary range, wages or what their earning statement stated. And similar, we see a range of questions around number and household. So it just says household size. Is the household size including yourself, or is it including your spouse and in your dependents? Is it people? Is it really looking at people over the age of 18 with income, or dependents under the 18 years of age? And so each time someone would have to complete this application, they would have to look at these questions and really think about what they actually are asking. Similarly, when we look at common ways to verify income um, around income tax and credit checks are the most common ways. When we started the search, I think in February, I'm trying to remember when, I think it was 2022 or 2024, sorry, February 2024. And then when we looked at we looked at it a few months later, we found this new process being introduced of credit checks now being used to verify income. And then the other thing I wanted to highlight that with income tax, it wasn't just that you had to provide your income tax, but you had to collect all the income tax for your family members. And so you had to go and ask them for that information as well. And then you also had to know all these different terms of WT and IRS 1040 and what those forms actually meant. For the credit checks, it was either involving agreeing to complete an application or providing a signature to confirm that you agree to this. And my concern with credit checks that I speak to about in the paper was just how this might be introducing new inequities. So the, historically, credit checks have had been used for discriminatory uses. So previously, when they were introduced, they were actually excluding people from getting credit from racialized groups and from actually being able to buy their home. Um, there's also considerations around how these measures were developed because we don't have a good sense of what actually is in those credit checks because these are um, measures that are used within an organization that doesn't share that information. And then the other piece is that people who may be on low income might not have their history of a credit that would actually be recorded within a credit check. So is it actually missing people who could be identified as having a financial need? The other thing that we looked at was around the additional information that was requested. Although these weren't as common, I found one or two applications actually requesting this information. And it would be things around asking around employment status. So you might have to ask for your employer's signed document. So actually to go to your employer and ask for that information. You could have to provide numerous statements around unemployment benefits, your workers' compensation, veterans benefits. One site actually requested your income, rental income, your additional assets, and then another one asked for your pharmacy out of year to date medication expenses. So you would have to collect all these documents to provide for your application. Sorry, I think I missed that slide. I'm just going to pause here for a sec so you can actually see this in a little bit more detail. All right, and then the other piece was around gathering signatures. So here we have the signatures agreements at the top. We also have the provider signatures, and then we also have the additional signatures. And so what you would actually have to do is agree to having a credit check, confirming what your insurance was, confirming your HIPAA authorization, confirming your Consumer Protection Act. And these often had quite detailed fine print with a lot of legal expertise needed to understand what was being requested. Your provider also had to provide a wet signature. And then under below here, you had additional signatures, which I still don't know quite the difference between a legal representative and an author representative. Are they different people? One application asks for a designated contact other than your healthcare provider, whereas another application asks for the opposite. So a healthcare provider different to your primary healthcare provider would provide that signature. So again, looking at the fine print and knowing who you have to gather signatures from. So I'm just going to pause there for a second, see if there's any questions or comments, or we're good so far.
We're good so far.
All right, perfect. So with all of that information, I looked at patients' administrative burden theory to understand what people actually have to do when navigating these medication affordability resources. So going back to our diagram here, what we're trying to do in achieving health equity, I looked at how administrative burden can actually be introduced through these medication resources and how that actually stops the process of being able to get access to timely medications. So administrative burden theory is from public administration, and it considers citizens' experiences with owners' policies on public resources like healthcare. Um, there's four types of costs involved. So there's learning costs, psychosocial costs, compliance costs. Temporal cost is a new one that has been introduced from recent research. And what we did is we mapped these four types of costs to possible actions patients may need to do when navigating the medication affordability resources. So learning costs is the cost involved with finding out about the resources and the differences between them and whether they're eligible for them and how to access them. Um, when we looked at this, we were like, okay, what are the actions that people would actually have to do to go across and look across these 66 resources to find out if they qualify for them, and if they can, and how to go about applying for them. So the first part was to really, they have to go and identify possible resources. So they have to sort through the 66 options. They then have to understand the differences between the types of resources. So what's the difference between an application, the coupons, the short-term supply? They then have to have the literacy skills for interpreting the information, have to understand the legal expertise that is being written within these documents. They also have to learn how, when assessing the match between their situation and their resource eligibility. So this requires reviewing the eligibility criteria. What I was surprised to discover was it was actually really hard to find out on some sites what are the eligibility criteria. And so people might actually be applying for something that they wouldn't even qualify for. The other thing is they have to complete income calculations to determine eligibility. And quite often there would be sites that said that you had to be above the 500% FPL. And so you had to understand what that meant. There was only one document I found that described how you could actually calculate that using your income. And then you had to interpret the question. So understanding what's actually being asked with that income calculation, it was the other piece to that. They then had to vet the organization. So looking at all these different groups and understanding what they might be using the information for. So you had to identify the source for the medication affordability resource. Was it a nonprofit organization, a pharmaceutical manufacturer, a local pharmacy? You then had to evaluate the organizational reputation. So what I found with when I was searching for coupons, I think we found over 50 coupons at one point, but many of them, the links were no longer working when we did our updated search a few months later, and so it made me question where these original sources were from. The other piece was weighing additional promotional benefits. So is it worth getting your loyalty points or is it worth getting the coupon and determining whether that's actually worth going to possibly different pharmacies in order to get these benefits. The psychosocial costs are the costs associated with the stigma of being unable to afford medications on one's own, and well as the loss of autonomy and increased stress arising from affordability resource related application processes. So when we look at the different actions again, what people would have to do would be establishing a timeline, because quite often these applications might require renewal. So you had to know um, not only how long the renewal was, but the wait time to access the resource. So some actually put that very clearly that it might be 7 to 15 days, it might be up to 30 days. Others did not offer that. And so just not knowing when you might hear back could add additional psychosocial costs. And then understanding which programs expire. So there was one that I found was available in February, but when we returned to it later in the year, their funds were no longer available, and so it wasn't even that it expired; it was just no longer available. Quite often, these programs required an annual renewal. And it wasn't clear what the renewal process might require. Did you have to restart the application or was there a reduced application just to verify your income hadn't changed? Compliance costs and administrative burden theory are the costs from the demanding applications and re-enrollment processes, providing documentations of one's financial standing, and avoiding or responding to discretionary demands. So when we look at the compliance costs actions, it's really having to follow the resources process so that you can get the resource. It might require detailing sensitive information. So as we saw in those applications, it could be detailing your health condition. It might also be detailing other health conditions, all your medications, as well as your financial history and your family's financial history. It requires providing documentation. So as we saw, it's gathering all those different documentations around your alimony, your income tax, your proof of your healthcare plan, and how do you actually get those documentations? Most places had you send it through a secure link or mail it. One actually said that you could email the information to the site. And then gathering the additional signatures. So what it would be like to go and ask your employer for proof of income, what it also is like to ask your family members for their income tax, can also add these not only psychosocial costs, but the compliance cost of having to gather these in order to qualify for the resource. The other thing that we looked at that I didn't touch on today for the sake of time, but we looked at coupons and to see how many pharmacies people would have to visit in order to get the listed savings. And so we used a patient case of a patient with 6 medications to find out how many coupons they would need and what pharmacies they would visit. And it turns out they would have to go to a different pharmacy for each visit. And then they might show up and actually find out that the coupon is no longer valid. And so they when they show up, what would they do in those situations? Would they actually want to confront the pharmacist and say, hey, I'm not getting this pricing? Or would they weigh that cost and decide, no, I'm not going to actually raise that as a concern? And then it's also around evaluating agreements about how information will be used. So sharing, identifying information, you have to provide this information, otherwise you won't qualify. Providing the additional health information, again, around health conditions and your other medications you may be on. Um, all of this, you have to comply in order to get that up to get that resource. And then agreeing to the resources terms so that you're okay with the credit check and you agree to the Consumer Act and the HIPAA regulations. The final cost is temporal cost, and that's the cost involved with waiting times for approvals and delays for programs like medication-related financial resources, financial assistance. So you really have to commit to the ongoing work of gathering this information. One site noted that in order to get the discounts, there's continually updates. So they recommended that you go to that site each time and check for any changes or any promotions. So having to do that each time you have a prescription renewal for each of your medications. The other is weighing the time with the financial savings. So using the example of a patient with 6 medications having to go to 6 pharmacies, is it worth going to these different pharmacies to have the financial savings? But it's also that additional cost of not being able to have your medications all in one place, but fracturing them across different pharmacies and what that actually may have for your health and implications. So when we go back to our diagram about achieving health equity, we find that the administrative burden that's being introduced, how could we actually think about introducing health informatics tools that reduce that administrative burden? So that's the next thing that we looked at in the paper, and there's a diagram that I'm just going to go through here. About how we can actually think about reducing administrative burden for patients. So if you look at the diagram, what we've proposed is we have all of these different categories that we found within the resources around income and documentation and calculation, eligibility criteria, application processes, patient information available in the electronic health record. And what we suggest is that you could actually take all of this information here and create a standardized around income documentation requirements and income calculation. Also around doing some standardization for eligibility criteria and standardization of proof of eligibility agreements and the required signatures. We could also then take the information that's currently stored in electronic health records and code it to the terminology and exchange standards. And then what we could actually do is take those two different databases and connect them to possible resources and provide a preliminary match. And so that so when you provide this preliminary match, if you don't require any additional information, it will match you to eligible financial resources. But we also recognize that this is a really complex system and that resources are constantly changing and that patients might not be able to gather the information that they need. And so really the importance of having someone who could help them through this process. So we recommend this idea of financial navigators that's currently being used quite frequently within cancer care. There's been a few examples where it's being used for people with chronic disease. But community health workers, care coordinators, or social workers could also serve this role in helping people to connect to these resources by helping them collect these documents and also understand the criteria. And really by matching up people, it takes us to what we're really trying to achieve in health equity, in really reducing the patient's administrative burden so that they can access the medication affordability resources, get timely access, and overall reduce their medication cost related non-adherence, and then really improve health outcomes and quality of life. So that is it. Thank you, everyone.